the foundation of newborn ventilation. As we told you earlier, the physiology of respiration, lung mechanics, these are the actually backbone of neonatal ventilation. 60% of newborn ventilation is actually the physiology and lung mechanics and the basics of respiration. And 40% is your machine. Today we have got a upcoming speaker, Dr. Rakesh De. Rakesh is the DM in neonatology. He is our direct student from IPGMR and SSKM Hospital. Currently, he is an HOD, head of the Department of Motherhood. As told by Sir, he is a very enthusiastic speaker. So today we will be listening to him on lung mechanics. I think we will not waste our time. I'll request Rakesh to start his talk. Rakesh,
Thank you,
please.
sir. First of all, I'd like to thank Neonatal Society of West Bengal, along with Subendu De sir, Arup sir, and Bijon sir, for giving me this opportunity to present on this important aspect of neonatal respiration, that is mechanics of respiration. And I also like to share my grand welcome to all the participants. Respiration is an important and delicate aspect of neonatal life, and to maintain the respiration and to know the different aspect of respiration coming with oxygenation, ventilation, and also the movement part regarding the chest wall and the diaphragm and the basic mechanics, it is very necessary for understanding the different pathology also, and to treat the disease and the pathology at the appropriate time for a better outcome. So without wasting any time, I will directly shift to my presentation. So compliance, time constant, work of breathing during the time of breathing, resistance, ventilation, and FRC and lung volumes pertinent to neonatal respiration. So to overview, first we will proceed with the lung development aspect and also the fetal neonatal transition, differences regarding the anatomical as well as physiological differences in case of neonatal lung, the control of respiration, mostly the neural control as well as the reflex function and the chemoreceptor function, the physiology of spontaneous breathing, and compliance, resistance, and time constant, as I have already told. So, from 3 weeks of gestation intrauterine period, it is consist of 5 phases.
Please go to the before slide, previous slide.
Rakesh, you are not audible. Rakesh, you are not audible.
Am I audible, sir?
Now audible.
Now audible.
Now audible,
Okay.
and please go to the previous slide. No, after that.
Start.
After this. Next, please continue.
Rakesh, not audible. Rakesh, you are not audible. Rakesh, you are not audible. Rakesh, you are not audible.
ও তো শুনতে পাচ্ছে না, সেই জন্যই
Sir, am I audible? স্যার শোনা যাচ্ছে কি? ও
শোনা যাচ্ছে। প্লিজ রাকেশ, প্লিজ কন্টিনিউ।
embryonic phase that is developed between 0 to 6 weeks of life, intrauterine gestation. Then pseudoglandular phase is 7 to 16 weeks. Canalicular phase is 16 to 25 weeks, and beyond that, that is secular phase till 36 weeks, and alveolar phase is 36 weeks to 2 years. So during the embryonic phase, most of the development is up to bronchi and the early part of the bronchioles. Then between pseudoglandular phase, the bronchiolar part and the terminal bronchioles have been developed. These are the main conducting zone that does not participate in the gaseous exchange. Then from 16 to 25 weeks, then some amount of respiratory bronchioles is started to develop. So at this phase, if the baby is being delivered at this phase, so as because the lung is immature and the surfactant is almost on the verge of developing from the type 2 pneumocytes, so the baby will be very sick and there will be a surfactant deficiency and the mortality rate is very high. Then in the saccular phase, the alveolar duct are coming to be developed and also the maturation starting to progress. And in the alveolar phase, it is starting from the late preterm age from up to 2 years of age. That is development of the alveolar sac and also increase in the number of alveoli in the lung. That is the main gaseous exchange. So coming to the next slide, that is the microscopic examinations of the rat lung module. It is a paper published in NEGM in late 2000 that shows that if we on the day one, if you see the histoscopic examination or the microscopic examination on light microscope and electron microscopic view, the alveoli are very few and only the transitional bronchiole or terminal bronchiole and saccules are present, and the septal that is seen with a red arrow that is very thick in manner. But on the next aspect, that is day 21, the alveoli are numerous compared to earlier development, and also the septal became more and more thinner, and the gaseous exchange surface had increased comparatively compared to earlier. So the baby will be able to breathe or exchange their gases properly. So coming to fetal circulation, as you already know the fetal circulation, I will only highlight the few aspects that in during intrauterine life, lung does not participate in the gaseous exchange. Most of the gaseous exchange in the intrauterine life is being taken part by placenta, and from the placenta the oxygenated blood is coming into the umbilical vein. From umbilical vein it goes into ductus venosus, and from ductus venosus to right atrium most of the oxygenated blood is then through foramen ovale comes to left side of the ventricle, and part of the blood is going into the coronaries and upper half of the body. And also the less oxygenated blood from the umbilical vein goes into the IVC, and also some amount of blood is going into right ventricle from where it bypasses from the pulmonary artery through ductus arteriosus and gone into left side of the heart, and from that the lower part of the body, and from lower part of the body most of the blood is being received, that is deoxygenated blood from the tissues coming into umbilical arteries and then gone into the placenta again for oxygenation. So that is the main fetal circulation. But after birth there are few changes occur. That is the transition is that after birth, due to the stretch receptors and also the inhalation effect of the baby, the pulmonary vascular resistance decreases and also the lung expanded. So the pulmonary blood flow is increasing in amount. So the pulmonary blood then go on into left sided of the atrium, and it increases the pressure of the or the volume of the left atrium. So that because of that pressure, the foramen ovale closes. So the right atrial pressure now decreases, and also because of the increases oxygen tension and increase in the amount of prostaglandin, the ductus arteriosus now closed down, and the most of the gaseous exchange is being taken by the lung itself. And also the ductus venosus that bypasses the liver also close because of the cord clamping that we done immediately after birth, and it closes within 2 to 3 days after birth. And also because of the clumping, umbilical arteries and the vein also closes. By this way the transition occur at birth. By any means, if the transition is not smooth enough, then the baby will develop certain cardiac features like PPHN and also the respiratory complications like TTNB with respiratory distress. Now coming to the neural control, though the neural control of respiration in neonate compared to the adult, it is very immature, but it is being mainly maintained by the central control, that is medulla and the pons. In medulla we have two types of neuron, that is dorsal respiratory group of neuron and ventral respiratory group of neuron. So the dorsal respiratory group of neuron is the main inspiration pacemaker, that is mainly responsible for the initiation of inspiration. On the other side, the ventral group mainly control the expiration part and provide the signal to the expiratory group of muscles in the chest. Then comes to the pons, that is they have a two center, that is pneumotaxic center and also the apneustic center. Pneumotaxic center is mainly the off switch of inspiration. It cut down the inspiratory phase, so the inspiration stops down and expiration starts. On the other side, the apneustic center is responsible for prolonged inspiration. By any means, if the apneustic central is being not controlled, then the baby will have a prolonged inspiratory phase, the expiration will not start enough. Then there are other chemoreceptor also. Chemoreceptors are central and peripheral in type. The central chemoreceptor mainly located nearby the medulla. Thus, main sensitive part is the raise of PaCO2 and also increase in the hydrogen ion concentration in the CSF. For this, the stimulation of the ventilation occurs, and through the nerves like vagus and glossopharyngeal, the stimulation of the respiration occur. On the other side, the peripheral chemoreceptor mainly present in the carotid and as well as in the aortic bodies, and the main sensation is or the stimulus is being provided by the low oxygen tension in the blood or in the alveoli. So coming to the reflex, the mostly in the neonate the reflex are predominant. The most common reflex is the herring-brewer reflex that is present in the airway smooth muscle. Upon stretching, it terminates the inspiration to protect the lung of the newborn and developing shallow rapid breathing whenever the reflex is being stretched. Then there are irritant receptor that is found in the airway whenever the baby or the adult population is exposed to certain smoke or secretion or gentle airway suction is being done. Then that because of the stimulation of that receptor, they cause apnea, bronchospasm and cough. Then the other receptor is J juxtacapillary receptors that is present in the alveolar walls near the alveolo-capillary membrane, that is being stimulated by the lung congestion or pulmonary edema. And because of that, the baby or the adult population will have rapid shallow breathing, that is tachypnea. The another reflex that is protective, that is seen in all the population, that is in the nose and the pharynx. Whenever the baby is aspirated something or reflux of milk or suctioning is being done, so there is a stimulation of the nerve and also leading to apnea and the laryngospasm. So, so this is the whole pathway of respiration. So here the stimulus or the sensor is being the decreased PaO2 or increase in the PCO2 or arterial PCO2 that is stimulated the peripheral as well as the central chemoreceptor, and the main regulator is the neurons that is present in the medulla and the pons. From that, the firing of the neurons occur and it stimulates the diaphragm and the inspiratory intercostal muscles and leading to increased ventilation. So the effector organ is the intercostal muscles. Now coming to important clinical implications of these neurons. In neonates, the receptors that are present, mostly the chemoreceptors, are immature, so they do not respond to the lower oxygen concentration and also in the higher H plus concentration in the CSF, leading to apnea and also bradycardia, and their brainstem neural control is also immature. For this reason, hypoxia management, we need to be very cautious to not to giving more oxygen to the baby that will causes hyperoxic damage to the lung and also prevent hypoxia for apnea trigger. And also to overcome the situation, as we all know, regarding to management of the apnea, certain stimulation like rubbing the back and also the positioning is very necessary, that causes the reflex activation and also restart breathing in the neonatal population. And also for therapeutic approach, caffeine is used for to stimulate the central respiratory drive that is weak in this neonatal population. So the neonatal respiration is like a fragile balance between the immature rhythm and also the blunted CO2 response in case of central chemoreceptor and paradoxical O2 sensing. Compared to hypoxia in neonate, they initially developed hyperventilation, then they developed into a apneic state, and also they have a exaggerated reflex function. So that makes their breathing comparatively unstable compared to older population and leads to apnea of prematurity and also SIDS. That is why we need extensive monitoring in our NICU and also in SNCU, and also CPAP and caffeine are the necessary intervention to overcome the apneic conditions. Now coming to the anatomical and physiological compromise in neonate. Regarding the chest wall function, it is comparatively cylindrical rather than ellipsoid in adult population. The ribs are more or less horizontal compared to the angular orientation in the adult population. Regarding the diaphragm, the mainly respiratory part is being taken up by the diaphragm compared to the intercostal muscle, and also the insertion of this diaphragm is more or less horizontal compared to the angular orientation in the older population. And also the muscle mass and the type 1 resistant fibers are very less, so the chances of fatigue in neonate is very common because the type 1 fiber that is fatigue resistant are very less in neonatal population. And also compared to adult population, they have a more stiffer lung and also high density lung that leads to low compliance of the lung, and also because of the narrower airway they have more resistance compared to older population. Now coming to surfactant deficiency, because of the immaturity of the lungs, the surfactant is not being produced to adequate amount by type 2 cells, so leading to collapse of the terminal alveoli in the initial part of early expiration. Regarding airway, I have already discussed that it is narrower compared to older population. So reduction in the radius according to the Poiseuille's law leads to increased resistance in the airflow during the type of breathing. And regarding the alveoli also, it is very fewer in number compared to adult population. So the gaseous exchange is less or very minimal compared to the older population. So coming to physiological difference, neonate usually have a higher respiratory rate. Also, they have a very lower FRC, that is functional residual capacity. the volume that is remain after normal expiration, it is very less, so they have a less oxygen reserve in their lung, so the chances of desaturation and the apnea and bradycardia are very common in neonatal population. And also they have a higher metabolic rate, so the oxygen consumption is twice. So because of the immaturity of the organ and also the control mechanism, there are more and more chances of hypoxia, and they have a predominantly diaphragmatic breathing. Regarding the volume status, they have a greater closing volume. Closing volume is being defined as the volume that is remained as the at the end of forced expiration compared to FRC, that is at the end of normal respiration. So in general or older population, FRC is more than closing volume. But because in neonate, the closing volume is more or less similar to the FRC. So the chances of dynamic airway collapse is very common during the time of expiration, leading to respiratory compromise in the neonate. So this slide is showing the spontaneous breathing, that during the time of inspiration, because of the it at the initial part of inspiration, the pressure inside the lung is called intraalveolar pressure. The pressure inside the pressure is called the transpulmonary pressure. At the initial part of inspiration, the lung has a equal pressure compared to the atmospheric pressure. So difference, so there will no flow inside the lung. But whenever in the inspiratory phase, whenever the muscles of the lung or the chest wall contract, because of the contraction of the diaphragm at the muscle, there is in the increased volume of the overall thorax, so that leading to increase in the volume, so that leads to decrease in the pressure of the lung, and that leads to increase air entry from the atmosphere to the lung during the phase of inspiration. On the expiration part, because of the relaxation of the diaphragm as well as the other intercostal muscle, the lung, the thorax volume is decreasing in amount, so the pressure of the lungs will increase. As because of the pressure of the lung increase, so the air is coming from the higher pressure area to lower pressure area. So from the lung to the atmosphere, the air passed out. So this is the
Rakesh,
whole. Yes,
Rakesh,
sir.
in the before your voice was breaking, so
Okay.
few of the delegates have not
Aspect.
listened here.
Okay, sir. Should I
Please,
repeat, sir?
yes, yes, yes. Please repeat.
Okay, so during the inspiratory phase, initially the alveolar pressure is equal to atmosphere pressure. So there is no airflow in the initial part. But whenever the muscles of inspiration contract, so there is a increase in the volume of the lung or the thorax. So there is a inspiratory airflow from the atmosphere to the lungs. But in the expiration part, it is completely opposite, because of the volume that is decreased because of the contraction or the relaxation of the muscles. So the volume in the thorax decreases and the pressure in the thorax increases, so the air is moving out from the lungs to the atmosphere. So I will I will in the next slide I will show the whole pathway in a AI generated video. So I am moving into the next slide. That is the important aspect, how the functions of the ribs occur during the time of inspiration. In our MBBS days, we have a very similar picture we studied during our MBBS days. That is the two mechanism, that is pump handle and bucket handle movement during the time of inspiration. So this mechanism of pump handle and bucket handle movement is very less in neonatal population compared to adult population, and the pump handle movement is being done by the upper ribs, that is mostly in the second to sixth ribs, and because of the contraction of the muscles, the ribs moves upward and the forward part of the sternum, so there is a increase in the volume of the lung because of the pump handle movement. On the other side, the bucket handle movement is basically the function of the lower part of the ribs, and it increases the transverse diameter of the lungs, that is the lateral dimension. So because of these two movement or the two functions, we get the increase in the lung volume, and that leads to increase in the airflow from the atmosphere to the lungs. So, but the neonatal difference is they have a horizontal ribs and also softer chest wall compared to adult population, and legs expansion from the rib movement. So the chances of diaphragmatic fatigue and the hypoventilation apnea are very common in neonatal population. So this is a slide showing the dynamics of breathing, and each of these funnel shaped image that is described as a lung. So in the initial part of inspiration, the PATM, that is pressure in the atmosphere, is equal to the PLV, that is pulmonary, that is alveolar pressure. So because of the matching of the pressure, there is initially no airflow into the lung. But whenever there is a volume increase in the lung, so there is a pressure difference is there. So the atmospheric pressure now increase compared to alveolar pressure. So airflow going into the lungs, that is in the inspiratory part. And at the end of the inspiration, again the pre-atmospheric pressure is equal to the p-alveolar pressure. So because of the similarity of the pressure, there is no airflow in the lungs. We have a expiratory phase. In the initial part of expiratory phase, because of the lower in the lung volume, the lung pressure or the thorax pressure is increased, that is alveolar pressure is increased compared to atmospheric pressure. So the air is moving out from the thorax to the atmosphere. And the last part is when the alveolar pressure is similar to the atmosphere pressure, then there is no air that is coming out from the lungs. In the lower part, it is showing by the blue line, that is volume part, black through the flow part, and pleural pressure, that is green line. So in during the time of respiration, the volume initially was on the lower side inside the lung, but at the end of inspiration, you can show that see that the volume inside the lung is increased. Then after inspiration, the volume gradually decreased in the phase of expiration. On the other side, in the flow part, initially the flow increases to maximize the volume in the lung. Then at the inspiration, the flow is decreases, and on the expiration part, the flow is reversed because the flow is coming from the lung to the atmosphere. And then the pleural phase pressure, that is during the phase of respiration, that is inspiration as well as expiration, the pleural pressure is always negative. It never becomes positive because of the elastic recoil of the lung and also the elastic recoil of the chest wall, that is opposite. So the pleural during the time of inspiration, it is less negative in the time of expiration. So in the next cycle, I will show you a video that how the breathing.
Rakesh, no voice.
Sir, hello. Sir, is it audible?
Actually, audio is not there. Video is there. Yeah. Not audible.
Nothing is audible here.
Sir, not audible.
Hmm.
Not
So
audible.
it is shown that you.
From beginning, you please start from the beginning. From beginning, it is not audible. Now, yes.
Sir, right, it is audible.
No, nothing is audible.
Okay,
I think
because
that
of the
is
net connection, I think it is not audible. The basic thing is that during the time of breathing, air is going, inspiration, air is going inside, and the expiration, it is going outside. So during the time of inspiration, air is going in. So that is the tidal volume. In neonate, it is usually 5 to 7 ml per kg. So air is moving because of the increase in the volume of lung. So the pressure inside the lung is decreases. So the air is moving from the atmosphere. That is being indicated in the arrow. So the pleural pressure is -5 at the time of inspiration. So in the next phase, so the so airway is moving from the high pressure to low pressure, that is in the alveoli, that is -1 during the time of inspiration to maintain 0 at the end of inspiration. So during the time of expiration, the alveolar pressure increase compared to atmosphere pressure. So the air is moving out from the lungs. So the at rest the alveolar pressure was 0. During the time of inspiration, it is negative. So the air is moving in from the atmosphere, and at the end of inspiration and during the time of expiration, it is positive alveolar pressure. So the air is coming out. But the pleural pressure throughout the inspiration and expiration, it is negative. So the transpulmonary pressure is the difference between the alveolar and the pleural pressure. It is positive throughout the respiratory cycle, but more positive in the inspirator part, that is plus 7.5 milliatmosphere. So now coming to the next part, that is elastic forces and the functional residual capacity, that is during the time of inspiration or during the time of normal breathing. If we consider this as a lung, so there is an inherent tendency of the lung to compress itself or to reduce the volume itself because of the elastic recoil. But on the other side, if you consider the lung inside a thorax, so the normal thorax is highly compliant, it has a tendency to expand, and lung has a tendency to going inside. So there is a opposite force that is working inside the thorax. So at that equilibrium, when the both the pressure is equal, that point is called the functional residual capacity. So at that FRC, the two forces balance each other and the equilibrium is maintained. And so in that in neonate, we have to maintain FRC for better compliance. And so if we not able to maintain that, then there will be a decrease in the oxygen reserve in the neonatal lung and also leading to hypoxia and also bradycardia. So during management of neonatal respiratory distress, maintaining FRC is very much necessary to prevent collapse of the lung. So early CPAP and also maintaining positive end expiratory pressure in positive ventilation, it is necessary to maintain oxygenation as well as to prevent atelectasis. So now coming to lung volume. So as you can see, tidal volume is being defined as the amount of air that is going in and around during the one normal respiratory cycle. The tidal volume is neonate, it is 4 to 6 ml per kg. Then RV is the residual volume, the volume remaining in the lung after forced expiration. And that is 20 to 23 ml per kg. and ERC, and also called the end respiratory volume, expiratory volume, that is forced force expiration, the volume remains in the lung. So that is 5 to 6 ml per kg. So in the next part, that is FRC, that is the volume remain in the lung at normal expiration, that is 25 to 30 ml per kg. So for practical purpose, we also only need to remember two things, that is the tidal volume, that is 4 to 6 ml per kg, that we need to maintain, and during the time of ventilation also, and also the FRC, that is functional residual capacity, that is 25 to 30 ml per kg. And total lung capacity, that is the total volume of air, that is 60 to 63 ml per kg. So breathing is an intermittent process, but because of the FRC part, the ventilation is continuous and the gaseous exchange never stops during the time of normal breathing. So the main implication is to maintain the FRC during the time of ventilation. So now coming to compliance. Compliance is basically tells us about how easily the lung can expand and overall the expandability of the stretchability of the lungs. So it is of two types, that is dynamic compliance and also the static compliance. In all practical purpose and also during the clinical part, we are only concerned about dynamic compliance. That is the compliance that it is generally because with airway resistance and also the lung elasticity play a role in case of dynamic compliance. So the formula is the change of volume in respect to the change of pressure. So in this slide, you can show that there is a loop, that is the loop is a volume by pressure loop. On the x-axis there is a pressure and the y-axis, that is volume. So in the first part, in the initial part, if we increase the initial pressure is very high, so that is the PEEP that is necessary to will get expand enough. Then after certain part, the wave is, that is the inspiratory wave in the loop. On the right side, that is inspiratory loop, and on the left side, that is expiratory wave. So the it is upright in manner, and the ideal is to maintain the curve in the mid part. That is the main area of gaseous exchange that can be easily taken place. So if you change the volume and pressure here, so the amount of volume that is changing, that is the main compliance. So the unit is liter per centimeter of water. So in normal neonatal population, it is 0.005 liter per centimeter of water. In RDS, because of the stiffness and because of the surfactant deficiency, the lung tend to collapse. So the compliance or the stretchability of the lung is very reduced compared to normal population. So the it value is decreases. But on the other side, meconium aspiration syndrome doesn't have that severe problem. The main problem is the resistance part, the resistance that is offered during the time of gas flow. So it is quite normal and also in the midpoint between the RDS and the normal lung. So that is now coming to static compliance. The static compliance is all about when there is no airflow. It is mostly used in the research purpose. When when there in the lung, the patient is breathing, the static compliance is not taken into account. It is the lung, when the lung is not at all getting any air, so there is a inspiratory pause, and the pressure, the change is from the alveoli to the upper airway. That is the alveolar pressure is being compared with the volume change. So in static compliance, we will tend to get an only one curve compared to dynamic compliance. Dynamic compliance, we get two loops. One is inspiratory area and other is expiratory part. And because of the elastic recoil of the lung, we tend to get a hysteresis or a loop type of picture. But in static compliance, we only get a steep type of wave, and on that wave, we have a lower inflection point and the upper inflection point. We have to maintain the ventilation part in the between lower inflection point and the upper inflection point, because in the lower inflection point is the minimal amount of pressure is needed to open the lung, that is the PEEP, positive end expiratory pressure, and the upper inflection part is that in spite of reaching that pressure we are not able to get that amount of volume extension of the lung, so the lung is stretched enough and the overextended lung. So if you increase minimal increase in the volume, but in the mid part, if you increase that pressure, so we will tend to get more change in the volume. So that is the main area of concern for neonatal ventilation. And in the upper part or the upper inflection point, that the lung has already been hyperextended. So if you are increasing the pressure, lung will not be extend enough. So that will cause more and more volute trauma. So we need to avoid this part. So during the time of ventilation, we need to keep an eye of the pressure volume loop so that the ventilation is being delivered properly. Now coming to the difference of static versus dynamic compliance, if you can see that pressure time scalar here, initially the during the time of end expirator, there is a PEEP, the amount of air that is being present in the lungs. Then the inspiration starts and also the inspiratory wave is being, inspiratory air or flow is being maintained until the flow, maximum flow is reached. That point is called PIP, that is positive end, positive inspiratory pressure. From that, there is a limitation of the flow and the area of no flow. That is, in that case, the pressure is called P flat or P plateau pressure. So, in case of static compliance, we are mostly concerned about that plateau pressure difference with P. But in case of dynamic compliance, we are mainly concerning with the difference of PIP minus positive end expiratory pressure. So now coming to a clinical scenario, suppose a preterm neonate with 1 kg with a diagnosis of severe RDS or respiratory distress syndrome is on mechanical ventilation, that is SIMB with pressure control mode with a setting of 20 by 5 with a tidal volume of 6 ml and the respiratory rate of 40. So the delivered pressure is gradient is that PIP minus PEEP, that is 20 minus 5, that is 15 centimeter of water. So now we need to calculate the dynamic compliance, that is the volume divided by the pressure difference. So the volume is 6, so need to divide 6 divided by 15. So that is the dynamic compliance. But in case the normal compliance is 1 to 1.5, so in this baby the dynamic compliance is on the lower side, so the baby will have a stiff lung that is consistent with the RDS. So what are our plans to recover from this state? So we need to give surfactant so that the compliance of the lung will be increased, and also to prevent the collapse of the lung, and we need to maintain a positive end expiratory pressure on the higher side, that is from PF5 to 7. So now the pressure difference lies at 13, that is 20 minus 7, and the tidal volume now increased to 10. So what will be the compliance now? So the compliance is 6 divided by 13, that in that is 0.77. Okay, so now if you feel that all is going well, so we can relax in our ICU, so you are wrong. So in this scenario, because of the management part you have done, the tidal volume has increased so much. Ideally, it should be 4 to 6 ml per kg, but in this case, the tidal volume is increased to 10 ml. So that will cause volute trauma. So we need to decrease the PIP, that is positive inspiratory pressure. So if you decrease the PIP, then the tidal volume will reduce and the chances of volute trauma will be less. So this is a video that is showing the dynamic compliance value along with pressure volume loop. The video does not have any sound. I think just observe the video part, how it is being shown in the ventilator, and you also need to watch out this, because during our daily practice we need to monitor the compliance to change our practice during the time of ventilation. Now you can see that the pressure volume curve is on on the flat side, because the compliance of the lung is low. That is shown it as a green type of graph. And also on the right side of it, C9 and C20 by C. So the dynamic compliance is 0.8, that is on the lower side, because in that patient the lung is wet, and also because of the RDS component the lung tend to collapse, so the compliance is on the lower side. And also in this side it is shown that the C20 by C value is 1.3. So now coming to C20 and C by divided by C value, that is an important part of ventilator parameters you need to monitor. So the C20 by C20 is generally is the compliance during the last 20% of the inspiratory phase. So in the pressure volume loop, if you look at the hysteresis or the loop, the terminal part is C20. So if the lung is very much hyperextended, so the C20 value will be less compared to the overall compliance during the phase of inspiration. So the overall value or the ratio will be less than 1. So we need to decrease the VT and also positive end expiratory pressure to prevent over distension. But on the other side, if the value is more than 1, then we could realize the fact that initially the lung was atelectatic or the collapse. So we need a greater pressure to overcome that atelectatic part or to recruit the lung. So we need to get a better PEEP compared to the low PEEP. Now coming to specific compliance, the specific compliance is little bit different compared to the general compliance part. In specific compliance, we are comparing the neonatal lung with adult lung. In neonatal lung, in these three scenario, the first situation when both the lungs are well ventilated and the volume are good. So if we calculate the compliance of the lung, that is volume divided by pressure, in the first situation it is 0.2. But in the second situation, the lung is reduced in the size. So the lung volume will reduce, and because of that the compliance will reduced. And in the third situation, there is very low lung or very low volume lung. So the lung volume is reduced in severe manner, that is 0.1 liter, the total volume. So the compliance is decreased in the very severe compared to the other previous situation, that is 0.02. But if we consider this in comparison to the specific compliance, that the formula is lung compliance divided by lung volume. So depending of the lung volume, the value will remain same in all the three cases, because in the other two situation, because of the low in volume, the stretchability of the lung will be less compared to the earlier lung. So the specific compliance is more or less similar all the three cases. That is necessary for comparison of neonatal lung in comparison to the adult lung. So the specific compliance is allow us to compare lungs of different sizes in a fairly manner. So newborn lungs may look less compliant, but if you only see the volume change, but when normalized to its lung volume, the lung specific compliance is similar to an adult. Now coming to resistance, Resistance is generally the block of airflow when during the time of respiration. It is of two type, because on the viscous resistance and as well as the airway resistance. So you can see in this picture it is calculated by pressure divided by the flow rate. So the viscous resistance is because of the lung issue, but because of the lung density and also the intra lung, the excess fluid that is being present, that poses a resistance to the gas flow during the time of inspiration. On the other way, airway resistance is because of the narrowing of the airway, the resistance of the airflow will be very much higher. So we could see from this formula, that is Poiseuille's law, that is resistance is being proportionate to the length of the tube and also the viscosity of the gas, but it is inversely proportionate to the radius of the tube. So if you divide the tube or the narrowing of the diameter or the radius, then the resistance will increase very much on the 16th part. And also, if in case of neonatal ventilation, the most of the ET tube is on the higher length, so we may get to see sometimes the in case of cutting the tube to reduce the overall resistance of the tube. So it is being expressed as an unit of what H2O, centimeter of H2O divided by liter per second. So more the length, more the resistance. So need to cut the ET short. Now coming to another concept, that is laminar versus turbulent flow. In neonate, in the distal part of the airway, the mostly the laminar flow is present, that the gas molecules are continuously flowing in the parallel manner, and it is also the, it depends on the radius of the tube, the velocity and also the density of the gas. It is mostly depends on the viscosity of the gas, and also the formula is Reynolds number. That is, if the value is more than 2000, then the flow will be turbulent. Then you can see that is a scattered flow inside the lumen, and mostly it is seen in the upper part of the airway, that is in the bronchia and the tracheal part. Because of the higher flow, the higher amount of flow, the resistance will be more in case of turbulent flow. So in this slide, we now compare the laminar versus turbulent flow. So in the x-axis, we will get to see the flow changes, and the y-axis, we will get to see the airway resistance. So if we initially, if the blue line is described as a laminar flow, that is linear, with increasing in the flow, we tend to get a linear increase in the resistance. But in turbulent flow, that is described in a orange line, if you increase the flow up to certain limit, it will be linear in manner, then it will grow down, go as a exponential increase in the resistance. So if you are using a smaller ET tube during the time of ventilated a neonate, so if you decrease the flow, that is 5 liter per minute through a ET tube, so the turbulence starting to begin, that is being described as a red dash line. And on the other side, the purple dash line, that is vertical purple dash line, if you increases the flow, that is 10 liter, so the flow becomes now turbulent, which was initially laminar. So the ET tube
Not audible, not audible. Rakesh, you are not audible.
হ্যালো, শোনা যাচ্ছে স্যার?
Go to the previous slide.
ওকে, হ্যালো So this slide is all about the laminar and the turbulent flow. So rigid, from blue line we are describing the laminar flow, and turbulent flow is described as a orange line. So we can see that resistance increases linearly with the laminar flow part, but in case of turbulent flow the resistance increases in the exponential manner. So we need to keep a appropriate ET size and also appropriate flow, because if you use a narrower tube with a increased flow, then we tend to get a higher resistance during the type of glass flow, so that will lead to breathing difficulty and also tachypnea in the neonate. But if you use a adequate ET tube or endotracheal tube during the time of ventilation and also adequate flow appropriate to the ET size, then the turbulence will be less, the flow will be laminar, and the breathing difficulty will be very less in that neonate. So ventilation will be very easy. Now coming to segmental changes of airway resistance. So here we can see that the maximum resistance, that is in the blue line, is being seen in the medium size bronchi, and the minimum is the terminal bronchiole and also in the respiratory bronchiole, because in the terminal and the respiratory bronchiole they are numerous in number, so that increases the gaseous exchange surface, so that leads to decrease airway resistance. On the other side, in the medium size bronchi, though the size of the airway is on the higher side, but the total cross sectional area is less compared to the distal part. So the airway resistance will be higher in the medium size bronchi. Now coming to inspiratory and expiratory resistance. So during the time of inspiration and expiration in neonate, it is not at all fixed resistance in the airway. It is more or less dynamic in nature. So during the time of inspiration, the airway resistance is on the lower side because of the dilatation of the airway smooth muscle. But in the expiration part, the airway tends to collapse and the resistance is on the higher side, so there will be limitation of gas flow from the lung to the atmosphere, and there is a increased difficulty of breathing in the neonate. So coming to the next slide, that is time constant, that is very necessary in our daily ventilation management. So time constant is defined as a time that is required for any lung unit to either fill or empty its content to 63% of its final volume in response to a pressure change. So one time constant is equal to 63% of emptying or filling of the total lung to maintain its equilibrium. So one time constant is approx 0.12 second, that is percentage equilibrium, it is 63%. So if we increase the time constant, that is 2, 3, 4, 5, then the percentage of equilibrium will also get higher. So 99% of the equilibrium between inside and the outside will become after 5 time constant. So in ventilation, the norm is to maintain at least 3 time constant, so that the ventilation or the resistance and the compliance part to be overcome during the time of ventilation. So the formula is resistance multiplied by compliance. So if the airway resistance is increases, so the time constant is also increases. So to empty the lung and also to filling of the lung will take longer time. On the other side, if the compliance of the lung is decreases, then like in cases of RDS or in cases of pulmonary edema, where the compliance is less, so the time taken to fill the lungs from negative pressure to positive pressure is taking very small amount of time. So the time constant in RDS is on the lower side compared to mass, where the time constant is higher. So in this slide, we are showing the different clinical scenario that is commonly seen in the neonate, that is meconium aspiration and also hyaline membrane, or that is respiratory distress syndrome. So in normal condition, we have a normal compliance of the lung and also normal resistance of the airway. So we get to see a normal time constant, that is 0.12 second. But in case of meconium aspiration syndrome, we have a higher resistance in the airway. So we get to see a longer time for lung to fill and also longer time for lung to empty. So we have a longer time constant. But in case of hyaline membrane disease, we have a low compliance because of the stiffer lungs. So we have a short time constant. So to manage hyaline membrane disease, we need to maintain a higher breathing rate with a lower tidal volume. So here in mass, that is B line, that is increase in expiratory time is necessary for ventilation management, and also we need to lower the rate of the ventilation to prevent air trapping, because lung will take more time to empty. But in case of hyaline membrane disease, because of the shorter time constant, we need a short inspiratory time and also higher rate and adequate PEEP to maintain the alveoli. So it is a, now I will show a video that is describing how the whole function is going on, taking into consideration the resistance and also the compliance part. I don't think the video will be audible. So in the initial part, we have a two balloon with equal compliance. Both the balloon have a equal compliance, but that one tube is narrow. So the narrower tube will have a higher resistance. So it will take a longer time to empty. So that is longer time constant. But in second scenario, both the tube are similar, so the resistance is similar, but the balloon is different. In one balloon, we have only higher compliance, but on the other side, we have put it one balloon inside the other. So because of two balloon, we have a better or higher compliance. Represents a thicker wall and therefore lower compliance. When the balloons are inflated to the same, so the balloon with a inside balloon that is having a lower compliance, so that will empty earlier compared to the higher compliance balloon. So it will take a lower time constant. So now coming to a practical example, that suppose in 1 kg baby, the compliance of the lung is 1 ml per centimeter of water, and the resistance that is showing in the ventilation, that is 30 centimeter of water. So now need to calculate the time constant, that is 0.03 second. But as of our theoretical knowledge, it is less than the normal value. So in that case, the time constant is less. So we need to increase the compliance of the lung by giving the surfactant, and also we need to give positive end expiratory pressure to maintain the proper time constant. So this is a slide showing different lung pathology, mechanics and ventilator parameters. I am not going into details of all this, but the main aspect is that in RDS we have a stiff lung, so the compliance is less. In meconium aspiration, we don't have any problem with the compliance. We have mainly problem with the resistance of the airway. So we have a higher resistance. But in BPD, we tend to get both having a lower compliance along with higher resistance. So we tend to get a long time constant. In pneumonia, we will get a variable picture, and also in case of bronchiolitis, we will get to see a more airway resistance during the time of expiration. So depending upon this compliance, resistance and also the time constant, we need to change our ventilation strategy for each one of these case. So like RDS, we need to get a better rate with a appropriate PEEP, but in case of meconium aspiration syndrome, we need a prolonged expiratory time. Like in BPD also and also in bronchiolitis, we need a proper high expiratory time so that the volume can be properly expired from the lung to the atmosphere. Now coming to the important part, that is work of breathing. So work of breathing is of two type, that is resistive work of breathing and elastic work of breathing. So resistive work of breathing is because of the gas flow or the gas molecule that is fighting one against another, and also the pressure of the molecule over the wall of the airway. On the other side, the elastic work of breathing is produced by the lung because of the wetness and the stiffness of the lung. So the total work of breathing is elastic plus resistive, that is volume by compliance plus flow into resistance. So now coming to the individual component, elastic work of breathing is to overcome the stiffness, and in RDS we tend to get a lower compliance, so the elastic work of breathing will get higher. So the baby will breathe faster, and also shallow breathing is being seen to reduce the elastic work of breathing. But in case of resistive work of breathing, the main problem is in the airway. The lung is okay. So we'll have a narrower airway, like in case of mass and with bronchiolitis. So baby trains to breathe at a slower rate with deep breathing to properly evacuate the air from the lung in the atmosphere. So here is the pressure volume loop, as I have already described. The horizontal part of the hysteresis of the loop is the resistant part. So on the right side, the blue part is being described as the resistive work of breathing, and the orange or peach color is being described as the elastic work of breathing. So in the next slide, I will show you the different condition and the shape of the wave. So the in the RDS case, or in the elastic work of breathing case, we tend to get a longer, taller loop and also wider loop compared to the normal work of breathing. And in case of resistive work of breathing, we tend to get a loop in the bulged out portion, that is the blue portion. The resistive part is bulged out and the volume is lagged behind the pressure part. So now coming to alveolar ventilation, and before going into alveolar ventilation, let us describe about the surfactant physiology in brief with a Laplace law. So Laplace law states that the collapsing pressure is equals to the two times of the surface tension divided by the radius of the alveoli. So in RDS, we tend to get a variable size of the alveoli. Suppose one alveoli is in smaller in size and another is larger in size. So according to the Laplace's law, the smaller alveoli will collapse fast compared to the larger alveoli, and leading to more and more ventilation perfusion mismatch, and lung will develop into atelectatic phase and leads to work of breathing. So to showing the example, in the first case, that the total tension, surface tension is 29 per centimeter, the radius is 100 micrometer. So if you calculate the uh, pressure, that is zero point 0.4, that is two times of the tension, that is 440 divided by 100, that is 0 0.4. But in the next case, when we are giving surfactant, so the surface tension is reduced. So from total surface tension that was initially 20 dyne, now the surface tension is reduced to 10 dyne. So if you now calculate the pressure, so the pressure becomes equal for more in the small as well as in the large alveolus. So the gaseous exchange now become normal and the baby will have a normal breathing. So now coming to the main alveolar ventilation, as you all know, minute ventilation is being defined as tidal volume into respiratory rate, but it does not taken into account of the dead space volume. But in neonatal ventilation, much volume has been contributed by the dead space, that is external by the endotracheal tube and the proximal ventilation sensor, and the internal, that is anatomical, the conducting pathway, and also the alveolar pathway, that is the non-perfused lung unit. So to calculate alveolar minute ventilation, we need to subtract tidal volume, dead space volume from the tidal volume, multiply by the rate of the respiration. So coming to this example, suppose a baby with 4 kg with a total volume of 6 dead space of 6 ml, and consider the tidal volume of different volume like 6 ml per kg, 3 ml per kg and 12 ml per kg. So in case of minute ventilation calculation, when the tidal volume is on the higher side, that is 6 in case of 6 ml per kg, the respiratory rate was 40 and the total volume is 960. But when the tidal volume is reduced, to compensate the tidal volume, we need to increase the respiratory rate of the neonate. So the respiratory rate now increases and the total minute ventilation became normal compared to the previous. And in case of higher tidal volume, when the tidal volume is given at a 12 ml per kg, so the respiratory rate reduced, so that is 20. So the total volume became similar to the earlier cases. But in case of alveolar minute ventilation calculation, we need to subtract the dead space from the tidal volume. So the dead space is 6, that is constant, and you need to subtract it from the different tidal volume that you are giving during the time of ventilation. So the alveolar ventilation will vary depending upon the tidal volume you are giving, but the total minute ventilation will be similar. So now the coming to important part, that is ventilation perfusion ratio. Dr. Rameshwar sir yesterday already have described the initial part of ventilation perfusion ratio. Now I will highlight the few important aspects. So before going into ventilation perfusion ratio, let us first describe the air blood barrier. It is being formed by the alveolar air epithelium and also the pulmonary capillary wall. The different barrier is being formed. Here has been notified from 1 to 7, and the most of the alveolar epithelium is being formed by type 1 pneumocytes, and the gases will come from outside to inside of the lung, from where it is diffused in the pulmonary capillaries, and then it is mixed with the RBC and the hemoglobin, and from also the CO2 will be passing from capillary towards the alveoli and from alveoli to the air. In neonate, compared to the adult population, this air blood barrier is less mature and it is thicker in amount compared to the adult population, but with gestation it is thinner, and also the capillaries became mature and the alveoli gets more and more thinned out, so the gaseous exchange will become more and more better. So now in this slide, we have seen 3 alveoli with pulmonary capillaries. On the first part, that is normal part, we have a proper normal ventilation, that the air is coming inside the alveoli and it is diffused in the pulmonary capillaries. Oxygen is going into the capillaries and carbon dioxide is coming from the capillaries to the air. So the ventilation perfusion ratio will become normal, that is 0.8. But in the shunt perfusion or the shunt defect, we tend to have a problem in the ventilation part. So the perfusion is normal and the ventilation problem in neonate mostly occurred because of the RDS or the airway obstruction or pulmonary edema cases. So we tend to have a perfusion without ventilation, so whichever blood is passing through the capillaries will not interact with the gases that is being present in small amount in the alveolus, so we will have a low ventilation perfusion ratio. But in the other part, like in dead space ventilation, we'll get to see a proper ventilation component, that the air is moving properly in and out of the alveolus, but the pulmonary capillary is defective. So like in case of PPHN or like embolism in case of adult population or cardiac shock cases, so the pulmonary capillary is not being perfused properly, so the gaseous exchange will not be developed, so the perfusion is zero, ventilation is normal. So if you divide that ratio, so it will be become infinity. So now coming to ventilation perfusion relation in different lung zone, that is calling west lung zone, that is not very proper in case of neonate, it is more or less distinct in adult population. So in the upper part of the lungs we will have a more alveolar pressure compared to the arterial and the venous pressure, so we will have a less ventilation and less perfusion also, but the ventilation is small less compared to the perfusion part, so we will tend to get a higher ventilation perfusion ratio, that is similar to the dead space ventilation. But in the second part, that is mid part, that is the adequate or appropriate part of gaseous exchange area, where the ventilation and the perfusion is all right, so the ratio is became normal. But in the lower part we tend to have a defective ventilation part, so we will tend to have a proper perfusion part, so the normal perfusion leading to decreased ventilation perfusion ratio. So the practical implications of this ventilation perfusion zone is that it is more prone to ventilation perfusion mismatch in case of RDS, where there is a problem in ventilation, so we will get to see more and more sun defect. But in PPHN we will get to see more and more dead space defect, because the problem is in the capillaries. And also the ventilation perfusion ratio or the gravity dependent ratio is less pronounced in neonatal population, so the difference or the clear cut zone is not seen in neonatal population. And also in neonate the effect of gravity is very less, rather than the positioning is important. So if you place the baby during the time of breathing in prone ventilation, like in adult or childhood we are giving ARV mode or prone ventilation, so that will increase the ventilation perfusion ratio, and that will lead to more and more oxygenation and also improvement in the respiration part. And in the other implications are that whenever we are ventilating the baby, if we are giving excess pressure, so that will lead to stretching of the lung and also collapse of the peripheral capillaries, so that will lead to more and more dead space type of scenario. So we need to give a adequate amount of map with low PEEP to maintain the or remain open the lungs, and also need to monitor the baby for appropriate saturation and also FiO2. So in case of shunt ventilation, if you increase the FiO2 like in shunt cases, but the saturation won't be increases, because the problem is in the ventilation patch. Until and unless we correct the pulmonary edema or lung issue, we will not to get to see the increase in the FiO2 part. But in case of dead space, because of the poor function of the pulmonary capillaries, the high CO2 will not traverse from the pulmonary capillaries to alveoli. So, in the blood picture or the blood gas, we will tend to get higher PCO2 despite normal oxygenation. So to summarize the whole neonatal respiratory mechanics, so that the lung is highly compliant and the chest wall is also very compliant, so that leads to overall reduced stability and also reduction in the FRC. So we need to maintain FRC through our ventilation technique as much as possible. The airway is having a high resistance, so we need to maintain a proper airway so that the resistance will be minimum and the work of breathing will be minimum. The compliance and the resistance together determine the time constant, so affecting the filling and the emptying of the alveoli. the ventilation and the perfusion mismatch occurs very easily in neonate, like in condition in RDS and mass, and the work of breathing in also increases in the either in the form of elastic load or resistive load, like in the increasing of the resistance of the airway. And also regarding the control of respiration, the neural and the reflex control is immature, so contributing to more and more apnea and irregular pattern. So monitoring and also management needs to be appropriate to survival of the neonate, and the strategy should be individualized depending upon the condition of the lung and also the response to your management, because sometimes uniform management across all population leading to harm rather than benefit. So we need to give a more shorter and fast breaths for stiffer lungs and longer expiratory times for obstructive lung disease or like mass or bronchiolitis cases. So thank you for all quiet listening. Uh, so now I will end my presentation, and if you have any doubt or questions, you can ask me. I will happy to answer any questions.
Thank you, Dr. Rakesh, for your nice elaborative discussion on mechanics of breathing. Few questions are there in the chat box. Now Bijan will summarize the whole thing, and Dr. Bijan Shah will take the questions from the chat box. Over to Bijan.
Okay.
Thank you, sir. Thank you, Rakesh, for the excellent comprehensive presentation of lung mechanics. I think Rakesh has nicely elaborated all the uh, uh, all the lung mechanics, whatever is there.
Please
First
stop.
of all,
Please stop sharing.
uh, just let me tell you what some of the important points he has highlighted, like control of respiration in newborn. The respiratory center is not that responsive. There is diminished response to hypercarbia, hypoxia, hyperoxia, etc. That is the reason newborn babies are very much susceptible to apnea. Second important thing he has highlighted is the compliance of the lung. So in simple language, it is the distensibility of the lung. And the third thing he has described is the resistance. Resistance is the friction of the gas in the airways. And then he has also described the flow. Flow is the speed of the gas. It may be laminar, it may be turbulent. And he has described nicely the time constant. One question was there, why in mass you keep there is a last time constant, you keep more expected time. You see, lung time constant is the time to inflate or deflate the lung. So there is inspiratory time constant as well as expiratory time constant. Inspiratory time constant is to fill the lung during inspiration. Expiratory time constant is to fill the lung during. So in the mass, the time constant will be more. If the time constant will be more, that means you have to give adequate time to deflate the lung. If you do not give TA time more, then there will be every time there will be stacking of air as autopeak. Just one important thing, just let me tell you, easy to remember. The smaller is the lung, the shorter will be the time constant. So tell me which animal has got the lowest time constant and which animal has got the highest time constant. You can start your mic, you can unmute yourself and you can tell. Hummingbird, very good. A hummingbird is the short time constant because it has a very small lung. And the lowest and the highest time constant. Thank you. Highest. Blue whale. Excellent. So if the size of the lung is very, that is why in preterm baby you keep respiratory rate around 50. In a term baby you can keep 40. In case of math, be on the higher side, then we have to keep respiratory rate, smaller respiratory rate, like 30. Then you can manage this thing. I think some of the questions were there. Uh, uh, so kindly explain the lower inflection point and higher inflection point in relation to the static compliance and C2 curve. See, as Rakesh has nicely described, when the lung is collapsed, like in RDS, normally what happens? First is the closing volume. Closing volume with the add volume what lung tends to collapse. Suppose lung is already collapsed, then you have to give higher pressure to open the alveoli. But once it opens, then you do not need to give higher pressure, you need shorter pressure. So in the initial portion of the lung, you give pressure volume curve, if you see, if there is RDS, then you have to give more pressure to open the alveoli. And once the alveoli is open, then you need less pressure. Second is that if you go on giving pressure, then at one time will come, so there will be no change in the volume, but there will be increase in the pressure, and that will lead to hyperinflation. So that is why it is said that if, if you draw a diagonal line in between the inspiration and expiration curve, that is the total lung compliance. So if your lung is hyperinflated, if you give more pressure, there will be no change in the volume. So last 20% of the compliance will be less. And this C20 by C means it is a total compliance. That means the diagonal line. And in the on the numerator, there will be last 20% of the compliance. So if the lung is hyperinflated, then you will not be able to achieve that much of volume or change in the volume during the last 20% of the compliance curve. So if there is hyperinflation, the C20 by C will be less than 0.8. That means in your graphics or in your calculated measures in the ventilator, if you see the C20 by C is less than 0.8, that means you are sure your lung is hyperinflated. You have to decrease the pressure. I think, is it okay? Hello?
Yes, sir.
Question.
Uh,
What is the role of pleural pressure during these phases, which was Rakesh, which you have told earlier?
Yes.
So,
uh, and
uh,
I think, tell.
The pleural
Tell.
pressure during the time of respiration, both in inspiration as well as expiration, because of the elastic recoil of the both the lung and also of the chest wall, that is completely opposite. Because of that force and also because of the surface tension of the lung, we tend to get a negative pleural pressure, and because of that negative pleural pressure we tend to get a variable pressure inside the alveoli both in inspiration as well as expiration. So if the pressure is variable inside the pleural, so the respiration will not be appropriate during the inspiration and the expiration part.
So what Rakesh is telling, in normal spontaneous breathing, respiration is negative. Baby creates a negative pressure, and that is more than the atmospheric pressure. That's why air goes in. That negative pressure is more than the atmospheric. But if some reason there is increase in the resistance or decrease in the compliance, that might not happen. In that case, baby will have increased work of breathing. Another important thing he has highlighted is the Poisson's equation. That means resistance is directly proportional to the length of the tube, viscosity, and inversely proportional to the diameter of the. That is the
Airway.
reason for airway or tube also. So if you take appropriate very smaller size ET tube, resistance will be more. If you take a longer circuit, then also resistance will be lower. One point to practical point. Many a times some companies will come, they will give a universal like of circuit. That is wrong. The circuit which is given, the recommendation given by the manufacturer, you should follow that. Suppose you take a longer tube for some reason, that means the resistance will be higher. Third is the viscosity. Viscosity means if there is secretion in the circuit, there will be this will also increase the resistance. If there is secretion in the airway, that will also increase the resistance. That is why when there is secretion, so you have to take care of the secretion. Fourth is the resistance increases during the time of flow. If the flow is more than the adequate flow, then also it will increase the resistance. That means these are all got practical implication when you are ventilating a baby. So when you are ventilating a baby, your tube size will be appropriate. There should not be any secretion. The length of the tube will be optimum. The compliance will be good. The resistance will be minimum. So you have to take care of everything when you are ventilating, and all these are dynamic. Whenever you are, he has already highlighted, if you give surfactant, the compliance will improve. When the compliance improves, immediately you have to come down on your pressure. If you do not come down on pressure, PIP or PWP, there will be early. So I think Rakesh has given an excellent view of lung mechanics. You can go through his lecture. I think that will be uploaded. And what should be the ideal flow? So ideal flow should be, let me tell you. Normally, what is minute ventilation? It is minute ventilation respiratory rate into tidal volume. Suppose your tidal volume is 5 liter in a 2 kg baby, and the respiratory rate is 50. That means 5 into 10 into 50 is equal to 500 ml. So normally what happens? To drive the gas into the airway, at least 5 times of the minute ventilation is required. That means 500 ml into 5 is equal to 2.5 liter. But so minimum 2.5 liters flow is required to drive the gas inside. But the for circuit also you need another 2.5 liter. So at least 5 liters flow will be required. Next important thing, how do you know your flow is adequate? Suppose we have set, when we will talk about ventilation, we have set a pressure of 15 and the flow of 5 liter, and ventilator is also delivering pressure of 15. That means your flow is adequate. I think I can. Is it okay?
Yes, sir. Yes, sir. Perfect.
And what is the minimum resistance and dead space? Normal resistance is around 20 to 30 centimeter water pressure per liter per second. And the dead space normally 1 to 2 ml per kg, maximum 1 to 2 ml per kg in a dead space in newborn. It should not be more than that. That is why he was calculating time constant. Compliance with resistance. Compliant was 0.005 and resistance was around 30. So 0.005 into 30, it will come around 0.15 seconds. So for one time constant is equal to 0.15 second. So if you, he has already said that the 3 time constant delivers that 95% of the tidal volume. So 0.15 into 3 is equal to 0.45. That is the reason most of the time we keep respirate I time around 0.45. Another way to remember, it is the gestational age which will be your I time. Like if the gestational age of the baby is 30 weeks, it is approximately 0.3. If the gestational age is around 40 weeks, it may be 0.4. There is a rough. C20 by C, I think I have already spoken. If you draw a pressure volume curve, inspiratory and expiratory, and in the between, if you draw a diagonal line, that is the total compliance. But if there is hyperinflation of the lung, the last 20% of the compliance will be low. So if you take the ratio of C20 means last 20% of the compliance divided by total compliance, definitely it will be less than 0.2. So if their compliance C20 by C is less than 0.8, that means you are sure your lung is hyperinflated. Is it okay? Hello? I think Dr. Joy was asking. Hello?
Any question you can unmute and question,
You can,
otherwise we will close the session.
otherwise we'll close the session.
If anybody has asked any question, please ask. Otherwise, we will close
We
the
can
session and next we will meet on day after tomorrow.
day after tomorrow. I think most of the question has been answered by Rakesh, and he has nicely explained.
Yes.
And once our participant go to the lecture, his video, I think tell then they will understand better. And you start reading, and also you try to practice what we have learned. And that way we can learn. Ventilation is a dynamic thing. Every day you have to see patient, see the ventilator, what is happening, then only you can learn. I think if there is no question, thank you very much. Thank you all the participants. They were very attentive.
Yes.
Until it's 10:40, still they are there and they are enthusiastic. See, if there is no question, I think thank you, Rakesh, once again for excellent presentation.
Thank you all, sir. Thank you,
And
PM sir.
it
Thank you,
is good to
Rakesh.
see
Thank you.
that.
Thank you.
Good to see that in our region we are getting excellent people,
Faculties.
faculties, and it is a good signal for us, all of us. Thank you very much. Good night. Thank you, sir.
I'm trying to send the YouTube link. I'm trying.
Sir, you should send the YouTube link and that will help them actually.
I'm trying. I have recorded today's and yesterday's also.
Thank you, sir.
I'm trying to do the YouTube link. If possible, it will be given to your WhatsApp group. Thank you.
Thank you,
Thank
sir.
you.
And
Thank
if you
you.
have got
Thank
any
you, sir. Good
questions,
night, sir.
you can start write in the WhatsApp group. We will be happy to answer. Thank
Yes,
you very
yes.
much.
Please
think
write in the
Yes.
WhatsApp group. Now we can close the session.
Thank you, sir. Close the good night. Good night,
Good night.
everyone.
Good night, everybody. Good night.
Good night.